Good morning. I'm Dr. Robert Ramirez. I'm a medical oncologist at Oxford Medical Center in New Orleans, Louisiana. I want to thank the organizers, including Elise, for the invitation for me to talk about knowing your lung neuroendocrine tumor. So lung cancer is a very common cancer in the United States. Well over 200,000 people were diagnosed with lung cancer last year. The good news here is the rates of lung cancer cases are dropping. Primarily, this is due to the drop in non-small cell lung cancer. But what we're going to talk about today is those patients with neuroendocrine tumors of the lung, specifically this little slice of the pie called the pulmonary carcinoid tumors. Now, the incidence of neuroendocrine tumors is increasing across the board, but what we're seeing increasing at the fastest rate is the neuroendocrine tumors of the lung. So what is a pulmonary neuroendocrine tumor? Well, number one, this is a lung cancer, and it does need to be managed by a cancer team. The symptoms of a neuroendocrine tumor of the lung can be highly variable. This can range from cough, including coughing up blood, to shortness of breath. I see patients with repeated lung infections, sometimes some chest pain, and sometimes there's no symptoms at all, and this is found incidentally because of a scan for another reason. What's interesting about neuroendocrine tumors, and specifically neuroendocrine tumors of the lung, is these can sometimes produce hormonal symptoms, including carcinoid syndrome. We don't see it a whole lot, but we certainly will see this occasionally. Other hormone symptoms include Cushing's syndrome because of an excess production of ACTH, acromegaly because of excess growth hormone or insulin-like growth factor, and sometimes SIADH. Now, there's different types of lung neuroendocrine tumors, and they all range in degrees of aggressiveness from very indolent cancers to very, very aggressive. What we look for underneath the microscope and what we specifically look for on the pathology report when our pathologist hands us this is a few different things. So mitotic index and the presence or absence of necrosis. And this is what is really going to define the difference between typical carcinoid and atypical carcinoids. When we start looking at the large cell neuroendocrine carcinomas and the small cell carcinomas, very high mitotic index and extensive necrosis. The one thing to keep in mind is, unlike the GI and pancreatic neuroendocrine tumors, where we also include Ki67, that role is somewhat evolving in patients with neuroendocrine tumors of the lung. I think it is very useful, and I do get it on all of my patients. So, importantly, lung neuroendocrine tumors do require a multidisciplinary team consisting of oncology, thoracic surgery, nuclear medicine, sometimes interventional radiology, pulmonary, and research. So it's really important to have your team in place. Surgery is the standard of care for early stage disease, and this is performed generally by a thoracic surgery familiar with non-small cell lung cancer treatment guidelines. It's important that the lymph nodes are evaluated during this time because survival is dependent on lymph node status and stage. Adjuvant therapy, or therapy after surgery, is somewhat controversial, and the bottom line is surveillance needs to be undertaken. So this is an NCDB analysis of patients with neuroendocrine tumors of the lung that were node positive, and they looked at patients who received or who did not receive adjuvant therapy. And what we can see in the patients with the carcinoid tumors, those patients who received adjuvant therapy actually tended to survive less than those patients who did not receive adjuvant therapy. In the atypical carcinoid tumors, these are the ones that are node positive that you would think maybe adjuvant therapy would be beneficial. We see those lines overlap, indicating no benefit to adjuvant therapy. Neuroendocrine tumors of the lung can metastasize. This is why we need to under surveillance. This is a study of over 5,000 patients that looked at all different types of neuroendocrine tumors, and you can see the frequency of lung metastasis was 27%. So what are our options for advanced pulmonary neuroendocrine tumors? Well, we have several, including ranging from observation. Everolimus is the only FDA-approved therapy for neuroendocrine tumors of the lung. We use somatostatin analogs, sometimes chemotherapy, and then the newest therapy at our disposal is PRRT using lutetium-177. There's other options that we sometimes use, not only in neuroendocrine tumors, but also in non-small cell lung cancer, including clinical trials. So this is our data for somatostatin analogs. We have two of them in the United States, octreotide LAR and lanreotide, and these are the survival curves for the PROMID study and the CLARINET study, showing an increase in progression-free survival versus placebo. I will caution that these were done in midgut patients and also in GI and pancreatic neuroendocrine tumors. So what is our data for somatostatin analogs in lung NETs? Well, there are no completed prospective studies in lung neuroendocrine tumors, but there is retrospective data showing activity to both of these agents. So I do believe this is a reasonable first-line metastatic option when your patient does need therapy, and it is supported by guidelines. The NETR1 study looked at the role of PRRT versus high-dose octreotide in those patients who, with midgut tumors who had progressed on standard dosing octreotide. So these were randomized patients to either PRRT versus 60 milligrams of octreotide LAR, and what they found was a very large improvement in progression-free survival. Again, I would caution this is in midgut neuroendocrine tumors, but we do have data supporting the use of this in lung neuroendocrine tumors, and specifically the two studies highlighted here did have quite a few lung neuroendocrine tumors, and looking at a progression-free survival benefit of 28 and 27 months, and also a high overall response rate of about 27%. So again, PRRT is a reasonable option for patients with neuroendocrine tumors of the lung. Another tool at our disposal is stereotactic body radiotherapy, or SBRT. This uses short courses of high-dose radiation, primarily in those patients who have a single nodule or mass that can be encompassed inside that radiation field. So this can sometimes help patients avoid surgical resection. So we use this primarily in non-small cell lung cancer for those patients who are not operable candidates or just don't want surgery. There is data in carcinoid patients. This is the largest data set that's looked at 184 patients who had received radiation for typical carcinoids. And this is the data looking at SBRT versus external beam radiation. And those patients with the SBRT treatment actually seem to do better than those with external beam radiation. This is an example of a patient of mine with an atypical carcinoid tumor. You can see a left lung nodule there. We gave her SBRT, and this is her post-SBRT scan. Our series showed 100% local control rate to SBRT. Other options could be liver-directed therapy for those patients with liver metastasis. This is a woman with a neuroendocrine tumor of the left lung that was placed on everolimus. We gave her 3 sessions of embolization, and these are her post-embolization scans. This is, again, August in 2017. I just saw this patient a few months back, and her scans look very similar to how they are right now. And finally, we cannot forget about clinical trials. Medicine certainly does not advance without research and clinical trials. So where do you start? Realistically, the best person to start out with is asking your doctor. There's lots of clinical trials at our institutions that we already know about, but sometimes the national organizations can also be helpful. So organizations like NETRF and Carcinoid Cancer Foundations can be helpful. Clinicaltrials.gov is shown here is a website that you can go to and search for certain terms, and up comes all the open and recruiting clinical trials. So this is also a resource. So I'll end by saying that after your diagnosis and your functional imaging, your case should undergo multidisciplinary review to determine if this is resectable, and if it is, a thoracic surgery consultation is indicated. If it's not resectable or if it's advanced, then we look at all of these options that I have spoken about. So I'll stop there. I want to thank you for your time, and as always, if there's questions that come up, please feel free to reach out to me at my email. Thank you.